A few tumours treated, gone, as planned. A few more tumours never touched, also gone. I cannot tell you why, and that is genuinely the whole point of this video. Some details in this case have been changed to protect the patient's identity, of course. The clinical sequence, the outcome, and the reasoning are real. Welcome back. On this channel, we don't just list symptoms and prescriptions, but we slow down and ask the uncommon questions that change real medical decisions, real cases, real evidence grades, and honest uncertainty when that's all that there is. Today, I want to tell you about one of those cases, one patient, one unexpected thing that happened, and one question I think is worth asking, even though I cannot answer it. Before I go any further, if you or someone close to you is living with prostate cancer right now or has been recently diagnosed, I want you to stay with me to the end. There is something in here for you, but not the thing you might think. And I will explain what I mean. My name is Dr. Michael. I'm a GP, a family doctor. I trained in the UK, and before I settled into general practice, I spent about a decade doing what I can only describe as a tour of everything medicine has to offer: emergency departments, surgery, pediatrics, cardiac surgery, and much more. I was even a ship's doctor for a stretch, which turned out to be my busiest and most challenging job. That career trajectory sounds impressive until you realize it mostly means I couldn't make up my mind. But it did leave me with something useful. I have actually worked in most of the specialties I now refer patients to. For the last 20 odd years, I've been in general practice, which means I see everything. The patient was a man in his 50s. He came to me, as patients often do, with a raised PSA, a prostate-specific antigen, which is a blood test that can signal prostate cancer or a benign enlargement of the prostate or inflammation, or sometimes nothing at all. My job at that point was straightforward: confirm the finding, investigate it properly, and decide what to do next. We confirmed it. And then we did something I want to explain, because it shaped everything else in this story. Rather than simply referring him onwards and waiting, I ran a full metabolic and nutritional panel, not because I had a grand plan, but because I had a strong instinct that whatever was coming, whatever the biopsy showed, whatever the oncology team decided, this man's underlying physiology was going to matter, and I wanted to know what we were working with. What we found: clear metabolic syndrome. He was significantly overweight, carrying most of it centrally here, with lipids, as in his cholesterol levels, HDL, LDL, triglycerides drifting in the wrong direction. And on the nutritional side, he had a low vitamin D, low B12, low folate, and low omega-3 levels. Now, the biopsy came back. He had several small tumours, mostly clustered on one side of the prostate, and he also had other tumours on the other side. These were considered intermediate risk, not the most aggressive grade and not dismissible at the same time. He saw the right specialists, a urologist and an oncology team, who designed a plan around cryotherapy, which means freezing, targeted freezing of the tumours. I will explain what that involves in a moment, but first I want to explain what I was thinking at the time, because it is part of the story most relevant to anyone watching this who is dealing with something similar. My thinking was this: cancer does not exist in a vacuum. It exists inside a body with a metabolic environment, an immune system, an inflammatory state, a nutritional profile. And there is now a serious and growing body of evidence that environment is not neutral to cancer. It is either working against it or working for it. I want to take a moment here to explain why, because I think it is one of the most important underappreciated areas in modern oncology, which is modern cancer treatment. In the 1920s, a German biochemist named Otto Warburg made a strange observation. Cancer cells, he found, behave very differently from normal cells when it comes to energy production. Normal cells, given oxygen, burn glucose efficiently through a process called oxidative phosphorylation. It produces a lot of energy cleanly. Cancer cells, even when oxygen is plentiful, prefer to ferment glucose, which is a much less efficient process that produces lactic acid as a byproduct. They consume glucose voraciously and incompletely. Warburg thought that this metabolic shift was the central defect in cancer cells. He was awarded the Nobel Prize in 1931, and then for several decades his central insight got somewhat sidelined as the genetics of cancer, mutations, oncogenes, tumor suppressors, dominated the field. And we have never actually stopped using the Warburg effect clinically. Every PET scan you have ever had, the ones that light up cancer on an image, works precisely because cancer cells consume glucose so aggressively that they glow when given a radio-labeled glucose molecule. We've been using Warburg's observation as a diagnostic tool for decades. We just did not always follow the therapeutic implications. A researcher at Boston College named Thomas Seyfried has spent the last 20 odd years following those implications. His argument, laid out in his 2012 book Cancer as a Metabolic Disease and in over 200 peer-reviewed papers, is that the Warburg effect is not merely a side effect of cancer, it is a central feature of it, driven by dysfunctional mitochondria. Cancer cells, he argues, cannot efficiently run the normal energy machinery, and so they revert to fermentation. They need glucose, they depend on it, and to a lesser extent, they depend on another fuel source called glutamine. His proposed therapeutic framework, the press-pulse strategy, published in peer-reviewed form in 2017, suggests that creating metabolic stress on the tumour by restricting its fuel supply while supporting the normal cells that can adapt to alternative fuels may complement standard treatment. Now, I want to be honest about where this sits evidentially. Seyfried's mechanistic observations are real and are in the peer-reviewed literature. The Warburg effect is not fringe, it is established biology. His specific therapeutic protocols are more controversial, and the human clinical trial evidence remains limited. We do not yet have large randomized trials proving that metabolic therapy added to standard cancer treatment improves survival across the board. The preclinical data is promising. The human data is early, and that is the honest position. But here is what we do have good evidence for. The metabolic environment of the patient matters to cancer behavior and to the immune response to the cancer as well. We know that obesity and metabolic syndrome are associated with higher levels of very inflammatory signals, interleukin-6, TNF-alpha, and others, and that these suppress the tumor-infiltrating lymphocytes that cancer immunology depends on. We know that elevated insulin and glucose create conditions that promote tumor growth. We know that intentional weight loss in cancer patients induces immune reprogramming, reducing immunosuppressive cells, activating anti-tumor lymphocytes, improving the immune environment around the tumor. These are in the clinical literature. So my thinking was, whatever this man's oncology team does to treat his cancer, I want his body in the best possible metabolic condition to respond to it, not as an alternative treatment, but as a foundation for it. So in parallel with the oncology pathway, we went to work. And again, this was his work, not mine. He changed how he ate. He moved more. He slept better. He addressed the specific measured deficiencies we had found. Vitamin D, corrected from a deficiency. The evidence that vitamin D plays a role in immune regulation is substantial. It modulates T-cell activity, affects natural killer cell function, and influences the inflammatory environment that tumors sit within. A 2025 systematic review and meta-analysis found that higher serum vitamin D levels were associated with improved survival and treatment response in cancer patients receiving immunotherapy. Not proof that correcting deficiency changes cancer outcomes, but a consistent signal in the right direction. B12 and folate, corrected. Both are essential for DNA repair and cell replication fidelity, the processes that matter most in a body fighting cancer. Omega-3, supplemented, consistent anti-inflammatory effects, some evidence for immune modulation and improved tumor microenvironment, reasonable safety profile, not transformative on its own, and probably not neutral either. And then lycopene, supplemented, multiple large meta-analyses, including a 2025 analysis across more than 100 prospective cohort studies, show a consistent inverse association between higher dietary and circulating lycopene levels and prostate cancer risk specifically. The observational evidence is moderate and consistent. The supplementation trial is more limited. Safety is good. It's worth including, and that's all I'm going to say about that at the moment. He lost a meaningful amount of weight. His lipids normalized, his inflammatory markers normalized and improved significantly. By the time he reached cryotherapy, the metabolic landscape was different from the one that the cancer had first grown in. Whether that difference mattered, I'm coming to that. The plan was targeted. The team's intention was to treat the main cluster of tumours and leave the smaller ones on the other side for now. Treat what most needs treating, preserve the surrounding tissue, watch and review. Entirely reasonable. So the procedure was done. On following up with his imaging, the treated tumours did exactly what you would expect. They were gone. The cold therapy had done its job. And then there were the others. The ones no probe had ever reached. The ones that received no local treatment at all. Those tumours also disappeared. On the follow-up scans, they were not treated, not touched. They were gone. I've seen a lot of things in 30 years. I will be honest, this was one of the ones that made me sit still for a good few moments. Now, there is a name for this kind of pattern, and it's got a history which is worth knowing about. In 1953, a British researcher named R.H. Mole was studying the effects of radiation on tumours, and he noticed something that did not fit the model. When he irradiated a tumour on one side of an animal, lesions on the other side, lesions that had received no radiation whatsoever, sometimes also regressed. He published this observation and, being a precise man, invented a word for it. Abscopal, from the Latin ab, meaning away from, and scopus, meaning target, away from the target. For decades, this observation sat in the literature the way a lot of inconvenient observations do. Noticed, documented, filed, and not discussed at grand medical rounds. Then, gradually, the immunology caught up. When you destroy a tumour locally, whether by radiation or cryotherapy or other ablative methods, you do not just kill cells quietly. You rupture them, you release tumour fragments, cellular debris, and danger signals into the surrounding tissue in a way that may, for the first time, give the immune system a clear picture of what the cancer actually looks like. The treated tumour acts, in rough terms, like a vaccine that's sitting there, priming the immune system to recognise and potentially attack the same cancer cells elsewhere in the body. It is a beautiful idea. It is also, in practice, exceedingly rare. A systematic review that collected abscopal effect cases from the entire world literature between 1969 and 2014 found approximately 46 documented cases. In 45 years of oncology across all cancer types and all treatment modalities, 46. The first documented cases involving cryotherapy specifically were in prostate cancer. 3 patients who showed regression of distant metastases in the spine, lungs, and lymph nodes after cryoablation, that's cold therapy, to the primary tumor. Now that number tells you this is a real biological phenomenon, but not a reliable one, not a predictable one. Something that happens rarely in some patients for reasons we cannot yet fully engineer. That is probably what happened here, a low-frequency abscopal response to cryotherapy. The simplest, most boring, most honest version of this story. And if you take nothing else away, please take that version. Did the metabolic treatment work? The weight loss, the corrected deficiencies, the omega-3, the lycopene, the restored vitamin D, the improved inflammatory state, did they change how this immune system responded to the cryotherapy? Did getting his body out of the high glucose, high inflammation, immunosuppressed metabolic state that Warburg and Seyfried and others describe as cancer permissive, did that make a rare immune event more likely to occur? I do not know. Honestly, I do not know. There are biological reasons it is plausible. The abscopal effect is an immune-mediated phenomenon. It depends on T cells and natural killer cells working properly. Metabolic syndrome impairs exactly those cells. Correcting metabolic syndrome restores some of that function. Vitamin D specifically supports the T cell activity that the abscopal mechanism runs on. The tumor microenvironment in a well-nourished, metabolically healthy patient is not the same as in a patient with chronic low-grade inflammation and insulin resistance. I cannot run the counterfactual, obviously. I cannot show you the version of this story where he did none of the metabolic work and got the same outcome. I cannot show you the version where he did all of it and the abscopal effect still did not happen. Both of those are perfectly possible worlds. The question, whether the metabolic preparation mattered, remains a question, not an answer. Here is the thing I would not want anyone watching this to do. I would not want you to hear this story and decide that metabolic health work, the diet, the weight, the vitamins, the omega-3, the lycopene, the sleep, is a replacement for cancer treatment. The cancer treatment in this story is the cryotherapy, done by specialists on an oncological plan those specialists designed. Without that intervention, the immune system would have had nothing to respond to. The spark that may have ignited whatever happened was the cryoablation itself. Everything else was, at most, the conditions in which that spark landed. And this is also the honest limit of Seyfried's work as it currently stands. His metabolic framework is intellectually serious and biologically grounded. It does not yet have the clinical trial evidence to replace standard oncological treatment. Using it as a reason to decline surgery, radiotherapy, or cryotherapy would be a misapplication of the science. The right question is not metabolic therapy instead of cancer treatment. It is metabolic therapy alongside cancer treatment. And what does that look like for this particular patient? If your team has not asked you about your metabolic health, your sleep, your weight, your nutritional status, that conversation is definitely worth having, in addition to everything else and not instead of it. Now, why tell this story at all then? Because R.H. Moll sat in 1953 and wrote down something that did not fit the model, instead of pretending it had not happened. And 70 years later, oncologists are running clinical trials combining cryotherapy with immunotherapy precisely because the biology he noticed turned out to be real. Otto Warburg described something cancer cells do with glucose a century ago, and we are still using it every day in PET scanning. Thomas Seyfried has spent 20 years asking what the therapeutic implications of that observation might be, and the honest answer is we do not fully know yet. But the question is serious and the biology is real. Medicine advances by noticing what does not fit and asking carefully, honestly, without overclaiming what it might mean. Something unexpected occurred in this patient. The untreated tumours regressed. The honest position is to hold both things at once. It happened, and we do not know exactly why in this man it happened. The most likely explanation is a low-frequency abscopal response, independent of everything else. There may be more to it. The honest position is to remain curious without becoming certain. Either way, there are very clear benefits in general for anyone's health, including that of a patient with cancer, in optimizing metabolic health. The question worth asking in any cancer case is this: in this particular person with this particular cancer, what are all of the things, including the quiet, unflashy ones like sleep and weight and nutrient levels and sport, that might support how their body responds to treatment? Not instead of treatment, not in competition with treatment, but alongside it. That is the uncommon question. It is not one I can answer for you, but I think it is worth putting to your doctor. This is a channel about real cases, one at a time, with the evidence honestly graded and the uncertainty honestly named. I'm a GP who's been doing this for 30 years and I still find medicine incredible, which either means I'm not very good at it or that medicine is genuinely surprising. Evidence grade for this case is preliminary. It is a single patient, an N equals 1. The metabolic disease framework is mechanistically supported and clinically promising, but human trial evidence is still early. It's important to mention I've got absolutely no commercial relationship with any supplement manufacturer. I mention everything in this video on clinical grounds only. If you are dealing with prostate cancer, yours or a family member's, I would love to hear from you in the comments below. This video certainly does not constitute medical advice. Please talk to your team for that. But I'm genuinely curious what questions are sitting with you that nobody has quite answered. This is The Accidental Doctor, where we try to practice uncommon sense medicine. I look forward to seeing you again in the near future. And thank you very much for watching. Ciao for now.